Hi, my name is Dr. Cheryl Burdette, and I am the Educational Director for Origins Incubator. And this week in our clinical discussions, where we meet every week and we talk about case studies, we talked about a gut refractory case. And I think this is one of the things that's so important about community. In general, if you had a patient with gut-based inflammation, you probably have a good feel for some ways to get started, various probiotics or glutamines, different anti-inflammatories for the gut. And so that's really not the issue. However, what if the things that you often do that usually work aren't working like you expect them to? Where do we go next? And the discussion in terms of what kind of testing comes next. And so in this case, what was seen was somebody who had ongoing watery diarrhea. They had had colonoscopy, ruled out IBD, and were left with more of just kind of a vagueness in terms of actual diagnosis. And so what we discussed was the general inflammation of the gut. And so stool testing had been done. And when that was returned, interestingly, even though this watery diarrhea started after a particular event in time that required antibiotics for gut-based pain and diarrhea. When we reviewed the stool test, what we were expecting to see would be potentially a pathogen that was undertreated. However, the stool test did not really note a lot of pathogenic bacteria or yeast or parasites, but there were other markers that were positive. Things like secretory IgA were extremely high. Well, that's the immune marker of the gut. That goes up when the immune system is reacting, usually to some type of infection. In addition to that, calprotectin was up, which tells us about gut-based inflammation, as does lactoferrin. We begin to produce more lactoferrin when we're fighting, usually bacteria. So all of these point to some type of infection and immune activation that would create inflammation, yet there's the absence of an actual pathogen on the stool test. So we talked about that and what that can mean. And so based on the watery diarrhea and the way things are presented, we decided that, okay, we just need this gut to take a rest. And so we talked about, for example, an elemental diet. And again, sometimes when you're getting started, you've heard of these things, but the actual implementation, haven't worked with them yet. And so just, having just some guidelines. So we talked about if you want to use the elemental diet for more of intermittent fasting and what that might look like for 5 days, or if you want to use it more as therapy, and that's going to require more scoops. And so, for example, more of a fasting schedule, you're really only looking at 2 scoops 3 times a day for 5 days. However, you're doubling that if you're using it more as just a meal replacement and not concerned with fasting. And then we talked about things that could be added to it to give it a little more calories and give people more satiety while they're getting through it, and just tips in terms of what makes it taste a little better. All of these things matter as we're getting started and can just really kind of feel overwhelming when we don't have somebody who's just done it before and can walk us through it. So we talked about that as a way to rest the gut. We talked about various supplements that serve as demulcents that will build the lining. We talked about why this presentation looked like a potential FODMAP patient. Every time they had sugar, even fruit, there was a level of reaction. So fructooligosaccharides seem to be something that they're not breaking down well. And so we talked about the sugar connection and some of what that means. And then how do we work with somebody like this? So we talked about various antimicrobials that would be appropriate. We talked about how berberine would make a lot of sense for this patient. Not only was there an elevation of neutrophils, not only was there an increase of MPO, which can be indicative of bacteria, but there was also this elevation of secretory IgA and also this feeling better after an antibiotic in the past, all clinically building the picture of some undertreated bacteria, even though it's not showing up on the stool test present. There were some other various markers this patient had, some issues in terms of LP little a and insulin, and since berberine helps in those areas as well. We found this to be a good choice as a broad spectrum antimicrobial that we can expect to improve diversity and deal with dysbiosis, and at the same time deal with some of the cardiometabolic issues they were having as well. We talked about that importance of improving diversity, some choices out there that have as many as 18 strains in them. And we talked about the importance of immunoglobulins really supporting the local immune system of the gut, but also walling off bacteria and directly dealing with the symptom that this patient was having, which was diarrhea. Immunoglobulins like IG26 are so effective in terms of decreasing diarrhea. And then what do we do about someone who has energy issues? Okay, we've got to really double down on multi, make sure things are getting in, and then talked about some of her poor insulin response and what might be done around that as well. Finally, there was an early AM elevation of cortisol, and the rest of the time her cortisol is normal. So we talked about how that AM stress response could be contributing to her loose stools, and in fact, morning is her worst time. And so we were able to walk through this complex case and see, what next steps would be that weren't redundant with things that she had done previously, and how a lot of the things in her picture really fit together to help move her forward. These are the kind of things that we talk about every week during our clinical curriculum piece. I really have a lot of fun with that, and I hope to see you there. Thanks for listening.